All right, good day, students. So this is a revision class for BCH 414, Clinical and Forensic Biochemistry. So these are the areas that you need to pay special attention to. You need to pay special attention to this as you prepare for your exam. Now, very importantly, look at this. It's expected that you should know the hypothalamic pituitary adrenal axis, the HPA axis. You should be able to explain it, and also you should be able to explain the HPG axis, hypothalamus pituitary gonadal axis. You must know how to explain it. So let's start with this HPA axis. What the HPA axis? Explain it. Explanation. The HPA axis is responsible for the neuroendocrine adaptation component of the stress response. HPA axis is responsible for what? Stress response. This response is characterized by hypothalamic release of corticotropic releasing factor, and then the subsequent binding of the CRF to the anterior pituitary gland, which in turn releases ACTH, adrenocorticotropic hormone. Then this adrenocorticotropic hormone binds to the receptors on the adrenal cortex and stimulates adrenal release of cortisol. So in response to stress, cortisol will be released for several hours after encountering the stressor. At a certain blood concentration of cortisol, this protection is achieved and the cortisol exerts negative feedback to the hypothalamic release of CRF and the pituitary release of ACTH. At this point, systemic homeostasis returns. So this is the chart. Simple. Just when you want to explain HPA axis, first thing is that you will draw this chart. The hypothalamus, the pituitary, and the adrenal gland. Okay? And then you will show that the hypothalamus releases CRH, positive effect on the pituitary. The pituitary releases ACTH, positive effect on the adrenal gland, and then the adrenal gland releases cortisol. Okay? So, at high concentration of cortisol, when the effect of the stress has been alleviated and restored to normal, then there must be a negative feedback from the cortisol to the pituitary and also from the cortisol to the hypothalamus. That is the regulation. So when they say, how is the HPA axis regulated? You say, when the concentration of cortisol has gotten to the maximum, then the excess cortisol sends a feedback inhibition message to the pituitary to stop releasing ACTH and also to the hypothalamus to stop releasing CRH. And with that, the entire axis is shut down and brought to normal. That is the explanation you will give. So there are two questions here. Explain HPA axis, which is this chart, then explain the regulatory mechanism, how it is regulated, which is the feedback inhibition mechanism from excess cortisol going back to the pituitary to inhibit the release of ACTH, and then excess cortisol going back, sending message back to the hypothalamus to shut down the release of further CRH. Alright, now let's look at some of the pathological conditions associated with HPA axis. So another question that may arise will be, what is the pathological condition associated with HPA axis? What is the pathological condition associated with HPA? Number one is Cushing's syndrome. Number two, Cushing's disease. And then number three is Addison's disease. There are three of them. Please take note. Three of them: Cushing's syndrome, Cushing's disease, and Addison's disease. So what's the difference between Cushing's disease and Cushing's syndrome? Cushing's syndrome and Cushing's disease are caused by elevated cortisol level. However, Cushing's syndrome is mostly commonly caused by chronically taking high amount of glucocorticoid medication. Right? So in that case, when there is excess release of cortisol by the adrenal gland itself, you call it Cushing syndrome. Cushing disease is a specific type of Cushing syndrome that develops as a result of a pituitary tumor. So when there is excess release of ACTH by the pituitary, you call it Cushing disease. So Cushing disease is excess release of ACTH by the pituitary, maybe as a result of pituitary tumor. Okay? But Cushing syndrome is excess release of cortisol by the adrenal cortex itself. Okay? So this is the difference. Then, what is Addison disease? These are another part of it. Addison disease is a disorder in which the adrenal gland don't produce enough hormones. That is enough cortisol. There is underproduction of cortisol. That is Addison disease. So, specifically, the adrenal gland producing insufficient amount of the hormone cortisol and sometimes aldosterone too. So when the body is under stress, example, during fighting or infection or maybe, this deficiency of cortisol can result in a life-threatening Addisonian crisis characterized by low blood pressure. So as you can see, the essence of cortisol is to help in stress response. So imagine if somebody is now having Addison's disease where the cortisol level is very low. It then means that when the person is subjected to stress, the body cannot handle it, and it will result in Addison's crisis, which most times is characterized by low blood pressure and shock or coma. So these are some of the symptoms of hypoadrenalism, that is low secretion of cortisol. You see some of the example. You see hypoglycemia, hypercalcemia, and anemia. Say high ACTH. So because of the low cortisol, there will be high ACTH, because usually since there is no more feedback from the cortisol, the ACTH produced from the pituitary will continue to increase. And once ACTH continue to increase, the next thing is that it will switch over into melanocytes. It will activate melanocyte stimulating hormone and cause increased pigmentation. Then you see low sex hormone, loss of body and pubic hair, loss of libido, amenorrhea in female, muscle wasting, and thin limbs. Okay. Also, you see there could be hypoaldosteronism. There will be low serum sodium, high serum potassium, dehydration, postural hypotension, weight loss, high plasma renin. So when there is adrenal insufficiency, that is low level of adrenal gland producing low level of cortisol, then you see all these symptoms will be seen, and that is symptoms of Addison's disease. Then what is the difference between Addison disease and Cushing disease? You can see in Addison, disease, this is this one, the person wearing yellow knicker is the man suffering from Cushing syndrome. The man wearing purple knicker is suffering from Addison disease. So the major difference in them is in the man suffering excess cortisol production, that is Cushing syndrome. You see hypercalcemia, you see hypernatremia, moon face, buffalo hump, one of the major buffalo hump, that is fat pad on the back. Then you see slow wound healing, you see truncal obesity, very, very important, truncal obesity at the abdomen, skin tanning, weak bones and prone to osteoporosis, purple/red stripe all over the body, that is a stretch mark, high blood pressure, rosy cheeks, hypokalemia, hyperglycemia. So please take note, hypernatremia, hyperglycemia, okay, high blood pressure, these are high. Truncal obesity, the only thing that is low there is hypokalemia. We have hypernatremia, hyperglycemia, all these ones, moon face, buffalo hump, very important for Cushing syndrome. Whenever you are trying to distinguish Cushing syndrome from Addison disease. Now look at Addison disease. In Addison, you have hypoglycemia, we have low mood, we have hyperkalemia, See, it is the opposite of Cushing syndrome. In Cushing syndrome, you have hypokalemia, but in Addison disease, you have hyperkalemia. Okay? Then you have low libido, right? You have fatigue, hyponatremia. So in Addison, you are having hypo, except kalemia that you have hyper. Then the opposite is the case for Cushing syndrome. So you see low blood pressure, hyperkalemia, hyponatremia, hypoglycemia. Okay, so then you see darkened skin, pigmentation of the skin because of the excess release of melanocyte stimulating hormone. So the just like as you are, if you watch now, notice that when you are subjected to stress, because of the increased release of your ACTH by the pituitary, some of them will be diverted into melanocyte stimulating hormone, and that is why during exam, due to the stress that you are passing through, some of you may get darkened. You see, you now become very black, very dark. Your complexion become very dark. This is because you have been subjected to stress, and in the course of stress, your pituitary release excess ACTH to manage the stress, and so some of the ACTH we are now diverted into melanocyte stimulating hormone and cause increased synthesis of melanin, causing your skin to appear very dark, and showing that really you are passed through stress. So that's a sign that your body is handling stress. So assuming your body does not produce, you are now experiencing adrenal insufficiency, as in the case of Addison disease. That means that excess cortisol that is being produced in your body cannot be regulated. There will be no feedback to regulate it and bring it back to normal. The ACTH will keep increasing, and then the case of the person will become very terrible. The person may even eventually die of low blood pressure and shock because of stress. So you cannot manage stress. So these are the very important pathological condition associated with the HPA axis. All right. So let's go to the next one, which is the HPG axis. When you are asked to explain HPG axis, draw this particular structure here. Hypothalamus produces GnRH, gonadotropin releasing hormone, goes to the pituitary where they bind to the receptors. The pituitary in turn will release LH and FSH, which will go straight to the gonads, which is the ovary and the testes, and cause the testes to start producing testosterone and spermatogenesis, whereas the ovary will produce estrogen, which will stimulate ovulation, and then also produce progesterone, which will also stimulate luteal phase, which will also promote the luteal phase and the uterine lining or menses. So this is very important. Then the feedback mechanism there is simple. Just the regulation is the feedback mechanism. How is it regulated? Simply, when there is excess estrogen and progesterone, there will be a negative feedback to the pituitary to stop the release of LH and FSH, and also to the hypothalamus to stop the release of GnRH. All right, but in that of male, the testosterone will send feedback, and inhibin and testosterone are produced, so they will send feedback to both the pituitary and hypothalamus to stop further production of LH and FSH, and the whole situation will come back to normal. So in female, there are times when there will be positive feedback instead of negative feedback. So negative feedback actually happens when there is excess release of the estrogen, okay? But in some cases, especially 24 hours before ovulation, estrogen level rises, and instead of sending negative feedback to the pituitary and hypothalamus, it will send positive feedback. That 24 hours before ovulation, estrogen switches into positive feedback mechanism, causing the pituitary to release more of LH. It is that LH surge that causes ovulation to take place. Without LH surge, ovulation will not take place. And without positive feedback mechanism by estrogen, then there will be no LH surge, and then there will be no ovulation. So take note of that, please. When you are explaining, if you can just read down this particular note here, very, very important. See it here. read it down, and then it's just the same thing that I have explained here. That is here. So if you can put it down the way it is here, that will be very good for you. All right. So what are some of the pathological conditions associated with the HPG axis? There are two types: hypogonadism and hypergonadism. Hypogonadism is what? A clinical syndrome that occurs when the gonad, that is the testes and ovary, produce low level of sex hormone due to a distortion of the HPG axis. All right. So there are two types of hypogonadism: primary and secondary. So primary and secondary hypogonadism. So there are two main types of hypogonadism: primary and secondary. Primary hypogonadism is caused by dysfunction of the gonads itself and can be acquired or congenital. When there is acquired dysfunction of the gonad, that is the ovary or the testes, then the acquired causes include radiation therapy, chemotherapy, autoimmunity, trauma to the gonads, that is somebody have injury, maybe accident that affected the ovary and the testes, certain infections like mumps or chitis. Somebody, all these things that children used to have in their early age, children, their cheek will swell up. It at times affect the testes in male. On the other hand, congenital causes, that is those ones that are caused by birth, from birth, okay, include genetic disorders like Klinefelter syndrome or Turner syndrome. So Klinefelter syndrome or Turner syndrome, both of which affect gonadal function regardless of the cause. So in this case, this leads to an overproduction. So in secondary hypogonadism, the cause is from the pituitary and the hypothalamus. So the pituitary is not producing, there is pituitary dysfunction that is not producing enough LH and FSH, and also the hypothalamus may not be producing enough GnRH in that case. So, but in the primary, the problem is from the gonads itself, that is the ovary and the testes. The testis is insufficient, or the ovary is insufficient, or maybe there is an acquired injury, or maybe an infection that is blocking their production. So this is very important for you to know. So in most cases, when there is primary hypogonadism, that is if the hypogonadism, the low secretion of hormones, sex hormones, and sex estrogen and progesterone and testosterone, and then if they are underproduced, then the negative feedback will not be there. And once there is no negative feedback, that means LH and FSH will accumulate and keep rising. And the other one is hypergonadism. It's a condition where there is a hyperfunction of the gonad. It can manifest as precocious puberty, a situation whereby a little boy is already developing male sexual secondary characteristics. So it's a result of hypergonadism, which can be caused by tumor or malignant, which can malignant, but is most commonly benign. Then maybe there is an intake of anabolic steroid, may also be a major cause of high androgen and estrogen function activity. Other possible causes include head injury and brain inflammation disease. Hypergonadism may contribute to symptoms such as precocious puberty and abnormal facial hair growth in females. So symptoms of hypergonadism: men and women exhibit different symptoms for hypergonadism. A few of the symptoms that men can experience are increased sex drive, early balding, excessive muscle mass, and acne on the face. Women can have symptoms such as increased growth of facial hair, deepened voice, coarse body hair, and an irregular menstrual cycle. Yeah. All right. Thank you very much. I will continue in the next class.